بسم الله الرحمن الرحيم. Dear colleagues, Assalamu alaikum wa rahmatullahi wa barakatuh. Today we have a very interesting lecture about myths and trust about anemia. This will be presented by D.عثمان Rضوي. He is assistant professor in King Abdulaziz University of Internal Medicine and Hematology. He has an American and Canadian fellowship in hematology and internal medicine and specializes in stem cell transplantation. And we welcome Dr. Osman.
Assalamu alaikum. Assalamu alaikum. Which one is working? Assalamu alaikum. You can hear me very well. Okay, thank you. I will probably. First of all, thank you for inviting me for today's educational activity. Inshallah, it will be a joyful time that we're going to share together. I brought some statements here, and I do understand that most of you would disagree with me, but we will try to solve it together, inshallah. It's fine. Just before I start with my talk about myth and truth about anemia, we all understand as healthcare practitioners and physicians that we know how to diagnose anemia, we know how to treat anemia. The easiest way. So diagnosis of anemia, the easiest way is check the CBC. If the hemoglobin is low, then this is anemia. Low, I did not say a definite number, because as physicians we understand if I know that my patient, his hemoglobin is always at 20 and suddenly it became 14, that is considered anemia. Although by WHO definition it's not anemia, but you understand as a physician and a wise person that this is actually anemia. And the easiest way to resolve the issue of the anemia is by giving the worst medication on earth, but necessary, which is the blood transfusion. So I do consider blood transfusion as a medication, but I do consider it also as a very tricky thing to give, given the fact that what entails the blood transfusion. Alhamdulillah, the transfusion services these years actually are being advanced in telling us more and more do not transfuse, or transfuse less whenever needed. So going through the first fact is iron deficiency equals to iron deficiency anemia. So as I stated, anemia on its own, it's a low hemoglobin. As we can see on the right side of the picture, the blue line, anemia actually is the last thing in iron deficiency anemia. So the hemoglobin level would drop further down the road. But the first thing that happens is actually the iron store. So the easiest way to check the iron store, or more feasible, is by doing a ferritin level. And it's not the most accurate. The most accurate is do a bone marrow biopsy. I wouldn't do a bone marrow biopsy to diagnose iron deficiency. But as you can see, the first thing is actually a drop in the ferritin level. And I brought the number here, it's actually 45, because this is the new definition from WHO for iron deficiency, that the ferritin value to be less than 45. So that actually, I do believe, and I do understand when you go deep in the guidelines, that they made this number higher than expected of 10 or 30, just to increase awareness that do the ferritin value. If it's less than 45, try to work up the patient for iron deficiency. This is in a normal person, the ferritin values would go low. The NAID, it's a very new terminology. It's called non-anemic iron deficiency. So you don't need anemia to call someone iron deficient. General anemia features, we all know about it. The patient will be fatigue, headache, palpitation, dizziness, chest pain, cognition. Even the cognition level would go low, and even postural dizziness. And the easiest question I like to ask my patient, when you perform prayers and you from sujood to stand up, do you feel dizzy or not? And most of my patients would say yes. All right. But my patients, remember, are always anemic. The second one is iron deficiency specific features. You don't need anemia to have these features. You don't need anemia. You don't need the anemia, but you need the iron deficiency. Astaghfirullah, for the nail health. So koilonychia will start even without anemia. Pica, eating, craving for ice. And I like to always ask this question to my patients. And surprisingly, they say, why you're asking? Yes, I am craving for ice. I am craving for mud. I bring the mud from a Nile. I go and bring mud from a Nile and try to eat it. I eat the peeling of the cucumber. I like to eat that peel, the green peel. Only just craving for different things, fix the anemia, and all that just goes away. And also restless leg syndrome. So people will have restless leg. The easiest question is basically asking, do you sleep with your partner, same bed? Do you always kick them? Are you sleeping right now in different beds right now? So fixing the anemia is going to fix the marriage as well. So fix the iron deficiency. And also hair loss, and our colleagues in dermatology and family medicine, they understand this a lot, and they do keep referring, alhamdulillah, to our hematology clinic too many times about iron deficiency. Second question is blood donors can get anemia from donation. We most of the time we do requested patients to donate, healthy donors to come and bring their family, relatives, whoever lives in the same neighborhood to come and donate for them. But is it always going to cause anemia for those people? Well, yes, it might. Well, you're taking blood out of them, okay? But you say, well, most of the time we're not taking that much of blood. Well, let's see. So this was a very nice paper. It's a randomized clinical trial, so a very high evidence of evidence-based medicine. Was done back in 2012, published in JAMA. What they did, they considered all comers at a hemoglobin concentration of 100, but they did check their ferritin values. And surprisingly, even though they are healthy donors, they come frequently more than 3 times a year, their ferritin level, which is in the, it's a small font, their ferritin level was actually, a few of them were actually less than 26, okay? So even though they are frequent donors, mashallah, they're giving blood so frequently. So they thought, okay, how about we do a randomized clinical trial? Half of them, we would give them an oral pill, ferrous-gluconate, ferrous, and half of them we don't do anything and see what happens. And surprisingly, you can see most patients in the yellow one, actually they came back with the squares, all right? In the yellow squares. They came back after 3 months to donate again with a higher hemoglobin than before their donation, just because a single intervention of giving them a single iron tablet. The same, come back to 100%. So the yellow triangles, they came back to 100%, so which is their regular fashion term. So 5-year follow-up post-bariatric surgery is enough. Do you think it's enough or not enough? Or maybe we only do 2-week follow-up. Okay. No follow-up at all after bariatric surgery. So we understand bariatric surgery is the common theme in our society these days for weight loss, either for medical reasons or for cosmetic reasons. They do come with sometimes with a package that, okay, follow up with a dietitian, that some our patients do comply, some do not. And even that, the maximum I have seen so far was 1 year of follow-up with a dietitian as well. Remember, those patients coming to do a bariatric surgery, they are, most of the time, they are well-nourished. They have been eating for many, many years. And we do expect that actually their anatomy, the GI tract is actually well preserved, and they are absorbing everything from their food. You come and do a bariatric surgery for them, name it, a sleeve, a diversion, a bypass, or whatever. And you have fiddled around with the anatomy, right? So the patient will come after 5 years, when all the storage has been depleted, telling you, doctor, I feel tingling sensation in my hands and feet. Doctor, my hair color is turning gray or light brown. I like it, but not that much because it's not consistent with all my body. I have different feelings. Fatigue is hitting me hard. Do I have another disease? Well, then the family doctor or the internal medicine internist would actually think about all these micronutrients on the left side and understand that whatever has happened to the patient is actually disturbing that micronutrient absorption. And unfortunately, the only way to replace that is by parenteral method, is either by giving intravenous iron or giving intramuscular B12, or giving a high amount supplementation of copper, all these micronutrients, essential vitamins as well. So all IV iron preparations are the same. So most of us has given IV iron once in their life career, even if they're not related to hematology, internal medicine, ICU, ER, obstetric gynecology, dermatology, just name it, GI. But are they all the same? So we understand actually from this table there are actually 3 generations. So the first 2 on the table actually it has been an obsolete. We don't use them anymore. They are not available even in the market, probably in some research labs only. And it is what actually brought the attention that actually giving IV iron would cause anaphylaxis. It causes allergy. Okay. The third one, which is the iron sucrose, which is in our Saudi market, is called Ferrosac. It's our beloved one that we actually give most of the time. Unfortunately, the maximum capacity for Ferrosac is 200 to 300 milligram at a single dose. When you do the Ganzuni formula to assess how much iron is missing and I need to replace, then the patient probably will come 5 to 10 times, 5 to 10 visits to get the IV iron. The third generation of IV iron, which is the Ferinject and the Monofer, so I'm bringing the pictures for them, and the reason, by the way, I'm bringing the pictures because they are the only approved Saudi FDA IV iron in the Saudi market, and luckily we do have most of them actually available in our pharmacy here at the hospital. So the newer the generation, which is the third generation, the less side effects you will get, the less amount of visits the patient will have to your clinic or to the ER to get the IV infusion, and even if all 3 luckily share that in 3 weeks their ferritin value will go up, but unfortunately after it will drop quickly. So then you will need after 2 months or 3 months to repeat the Ferrosac IV iron. But in the other new generations, it can go up to 1 year that you do not need to give it again. And remember, the newer generation, a single dose. Monofer, we can give it a single dose of 1,500. So it saves the patient 5 visits. Iron sucrose or Ferrosac is the only safe IV iron in pregnancy. So if you're dealing with a pregnant lady, just say IV Ferrosac has been in the market for very long time, given also it's more cheaper than the others, so it's more feasibly or widely available. So most of our beloved colleagues in obstetric gynecology are using Ferrosac more frequently. Then it just keeps sticking in the mind. Okay, I'm familiar with IV Ferrosac, so I'm only going to use IV Ferrosac. Well, there has been many randomized clinical trials with the third generation IV iron, so Ferinject, not so much with the Monofer, but is giving an idea that it's actually safer to give. But let's think about our beloved part of the society, which are the ladies actually who goes pregnant. So always with the hemoglobin less than 11, check the ferritin, because it's not routinely checked in the antenatal care for obstetric ladies. Check the ferritin. If it's low, give oral iron, especially in the first trimester. Try to avoid IV iron in the first trimester. It has not yet been well studied. And by the first trimester, you can even make a cut line like gestational age of 13. And this also allows me to remind myself and everyone in the room, if you're giving IV iron for a young lady, ask when was her last menstrual period. Do a pregnancy test if necessary, because if the lady has a fetus growing in her womb, you don't want to give IV iron because it's not tested. It's not teratogenic, but it has not been tested. Actually, in this, I brought it from a very famous series in hematology. It's called How I Treat. So if you want to treat anything in hematology, just type how I treat something, and it will show up. So this is how I treat anemia in pregnancy. And it was published in 2017, and here actually they say give oral iron twice daily. Where is it? Yeah, give oral iron twice daily. And this will help me in the next slide. Just keep it in your mind. So IV iron versus oral iron has been studied head-to-head, meta-analysis of 10,000 patients, and they all agree that it has same pregnancy outcomes. So it's not you're not giving IV iron. That doesn't mean that you're not treating your patient well. But better vitality and functioning with IV iron. Remember, it's a pregnant lady. She has back pain. She has everything. Add on top of it the brilliant side effects of Ferrose, like constipation, metallic taste. That prego will not like you. Okay. And third generation IV iron is taking the lead right now in pregnancy care. Drinking tea with meals interferes with iron absorption. So what we always do whenever we prescribe oral Ferrosac or our beloved Ferrose, you have to tell your patient certain things to ensure that the absorption of the oral iron is getting better. Take it 2 hours before meal or after meal. Take it with a citrus, anything that contains citrus, orange juice, lemon juice, kiwi, all right? Suntop, okay, it's fortified with vitamin C, as far as I remember. You can also ask your patient not to drink tea with it, and it's actually written in the pamphlet, all right? Because tea actually has tannic acid inside it. But is this really true or not? So it has been looked at, and very few studies contradicting results, saying yes, saying no. And even when you go to the methodology of these studies, you're going to find that they use different type of tea. Like even, for example, I'm not talking about just only green tea, Chinese tea, red tea, black tea, but even like what, I don't know what's the English term for it, but شاي تلقيمة ولا بوكيس ولا يعني even different. And even the number, like the maximum number of population in the same study, or the sample size was 30. So it's not that number that you would like to infer results from, okay? Folate deficiency is common in the youth, all right? So where did I see folate deficiency in my life career, which is shorter than Dr. Yahya's for sure, okay? It's basically, you have either people who drink alcohol all the day, they're relying on alcohol for their calorie intake, so they don't eat any other nutrients, and like even they're low in ferritin, B12, and folic acid. And the other people are our beloved, neglected geriatric people. So even if the son or the daughter is taking care of her father or mother or elder brother or elder sister, providing them shelter, providing them a place to sleep, hired a sitter also with them, taking care of the meals for them is not always the fact actually that goes around. So most of them would come to you with a folate deficiency. And the easiest way, single test to test for that is if you don't have a folate level, is by measuring the CBC and check the MCV. If it is higher than the normal, then the patient needs workup. So the recommended daily, I would disagree with this, that is common in our youth. The reason is the recommended daily dose is 400. If they're relying on this lovely biscuit, OREO, okay, then even eating 2 a day would be 100 micrograms, so I don't think our youth would stop at 2. If you, folic acid. So, no, I did not say OREO. What is, I don't know, okay. So this double cheeseburger from the famous fast food. حتى لو أنا متعاقد مع الثانيين كان زبط معايا. So the double cheeseburger has 80. It's fortified, and even our beloved fat noodle. Okay, the one I'm not going to say the name. Okay, it has actually 100 micrograms. So if our youth ate these, okay, inshallah they will get enough folate. But I'm not advising to do that. Okay. Junk. Folic acid is available anywhere. Okay, even in one of the cornflakes that we do usually eat, everything is fortified with folic acid. So patients with sickle cell anemia requires iron supplementation. So remember, in Saudi society we have 2 types of sickle cell that we usually do encounter, or we don't know that we're encountering those patients. We have a sickle cell trait. It's sleeping. It's a gene that it is there, but it is sleeping. It's not causing problems. And we have the sickle cell disease patient that their manifestation would start even from the age of 6 months. You know that they're going through vaso-occlusive crises, pain, transfusion, and infections as well. So most of the time, we don't know about those who have sickle cell trait. We do have in Saudi Arabia the biggest amount of data about the prevalence data for sickle cell disease from a single test that has been compulsory by the government to be done, which is premarital counseling. In premarital counseling, anyone who wants to get married and register their marriage in Saudi Arabia, they have to get a hemoglobin electrophoresis done. And so we have a 12-13 million of hemoglobin electrophoresis data about prevalence of normal people who come, and the prevalence of sickle cell disease in our country is high. But when I say this statement, I go back, is giving them iron would help their sickle cell disease problem or not? So it's all about polymerization. In a sickle cell disease patient, you want to stop the polymerization. You want to stop the RBC from going from the nice donut shape into the sickled shape, all right? And so you stop the polymerization, you're going to win the battle for sickle cell disease. You stop the polymerization by hydration, by lowering the stress, by giving hydroxyurea with all its magnificent, marvelous effect on the hemoglobin. So iron deficiency, what was found actually, it actually halts the polymerization process. It slows it down, all right? So if the patient keeps drinking later, till the polymerization happens, it restores. Iron replenishment actually fastens the polymerization process. So we tend to not to give iron pills or iron supplementation to patients with sickle cell disease. I'm not talking about the traits. We're giving to sickle cell disease, please do not give iron. Give folic acid. Health practitioners know how to ask about the menstrual cycle. I don't know who agrees or disagrees. Any in the room thinks that he knows how to ask about menstrual cycle? It's a very weird question, I understand it, but unfortunately in our society, we do shy away from asking ladies, even if they come with diabetes or even if they're coming with DKA, we don't usually tend to ask about their menstrual cycle. And remember, I'm talking about anemia, so yes, it has a relation with menstrual cycle. So these are the 5 main questions we do ask. What's the frequency of period, duration of blood loss, how many times she changes pads per day, whether the pads get soaked with blood, presence of clots and their sizes. Asking these questions, I can tell you from my experience, it gets tense in the room, okay? Why a man myself, is asking a lady these questions, all right? And I do apologize beforehand to the patient, but it is really necessary to ask. Because usually I get the answer, how's your period? She says, normal, or it's regular. Define to me what is regular. Define to me what is normal. So by asking these questions. And the one that I found actually, myself, okay, it's not evidence-based, expert opinion, if you consider me an expert, is basic. If the patient tell you, I cannot leave the house on those days, I will skip work, I will skip school, I'll go social on those days, trust me, she has iron deficiency anemia. Okay, just test the CBC and the ferritin values and she will be. And I remind you all about this lovely medication, tranexamic acid. The way we order it here is cyclocapron, 1,300 to 1,500 milligram on heavy bleeding days. So I ask our beloved ladies who go through heavy menstrual bleeding to take it on those days only, okay? Because the reason why I brought 1,300 or 1,500, because we have the 500 formulation or the 650. So she takes 2 tabs or 3 tabs, her life will go better. She will come back and thank you, trust me, in the clinic. Sorry? It is antifibrinolytic. So it stops the menstrual bleed. Not stop, lessen the amount of bleeding coming out. So tranexamic acid so think of any bleeding in the human body that can encounter. CNS bleed, GI bleed, epistaxis, pulmonary hemorrhage, hematuria, GI bleed, all had randomized clinical trial. And the postpartum hemorrhage, yes, postpartum hemorrhage. The most common cause of death in ladies peripartum in the third world country is postpartum hemorrhage. Woman trial is amazing. Alhamdulillah, it saved life, this medication. It did save lives, okay? And if you found the price of the water bottle went up, you understand why. Because Uthman Rضوي put tranexamic acid in the water. I want it to be in the water, okay? It has very, very minute side effects. And because we are all physicians, it has been proposed the theory that if the patient has hematuria, a male has hematuria, do not give him tranexamic acid because it will cause a clot in the urethra, causing urinary retention. I would ask you to use your due diligence in that case, thinking if the patient is already admitted into the hospital, he has urinary retention, you can easily put a Foley catheter in and save that matter. If he's going home, do not give him, if he has hematuria. And the second thing would be in GI bleeding. In all randomized clinical trials, tranexamic acid won, except GI bleed. Unfortunately, it lost. And it caused more mortality in GI bleeding, so do not use it in GI bleeding. Okay, so last one, promise you. Hemorrhoidal bleed can lead to anemia. Do you, yes, no? Yes. Okay. So on the long term, yes, it will cause this, and I brought this slide to also bring awareness to the fact that even small bleeds, epistaxis from time to time, menstrual cycle that has been regular, okay, from time to time. Hemorrhoidal bleed, that's not really significant bleed. They say just when I wipe, I will find just a little amount of blood or a blood streak on top of the stool. Forgive me, or mind me. So then, yes, it has been studied. Can patients with hemorrhoid develop anemia? And it was found, yes. And actually, when you fix the problem, you have to fix a problem in anemia. Anemia is not a disease. Anemia is a manifestation of something. We always have to look why the patient is anemic. Is it an inherited anemia, acquired anemia, bleeding, hemolysis, nutritional? So, and they found that whatever they fixed the problem, the hemoglobin concentration went back to an expected range in the patient. So these are the 10 facts that I brought you earlier. So I hope most of you agree or disagree. The one that we said I don't know is drinking tea. And health practitioners know how to ask about the menstrual cycle. I cannot say yes or no about that. Okay. And if you have any more questions, I'm willing to take.
About the donation, we donate the
So blood donors can get anemia from donation. Yes, they can get. Wallahi, we are all doctors here, sir. I do encourage to donate. Always we encourage to donate. We all understand what happened in COVID-19. We read in the books, please, donors, go and donate. But what happened in COVID-19 was a shortage of donors. Donors don't want to come to hospitals. So we went through crisis, wallahi. It was a crisis that we cannot even do operations because blood is not available to us. But we do encourage to donate, but those who come as frequent donors, the frequent donors, they are giving to us, and they're not patients, okay? They're giving to us. It is wise actually to give back to them a thank you, a firoz. take it once a day, okay? In a way that will not cause a GI upset. Thank you so much. So, take it up. Many questions have been asked. I will try to tackle them one by one quickly. So the first question was about using IV iron in pregnancy. Okay, so IV iron in pregnancy is, I'll talk about from experience, and a shared experience because we do sit most of the time with many other experts in the field. If the ferritin value is less than 10 in a pregnant lady, if the ferritin value is less than 10 in a pregnant lady, or non-pregnant, just a normal male or female, you will never win the battle by giving oral iron. Never. You can never reach it up. Even if let them improve their diet, let them improve anything.
So the level of 10.
The level of 10 is actually telling you your patient really needs. I can tell you I have seen so many ladies, pregnant ladies, with a ferritin value coming in the lab undetected. So not we don't give it. So second trimester, third trimester, no teratogenicity, no issues with the pregnant ladies. Side effects that might happen to a normal person can't happen to pregnant ladies. We're talking here about, I don't like to mention it, but I will mention it. Changing in the skin color for some at the site of infusion. Okay. And on the long term, the newer generation are causing hypophosphatemia. I don't think we know how to treat, we know how to diagnose hypophosphatemia from patient symptoms, but I will bring you back to medical school when we studied the Krebs cycle and all the stuff about ATP. So you need the phosphate for the ATP, the phosphorylation process. So patient will come with very, I can tell you, whenever we give IV iron, they come with very weird side effects that we will tell the patient just slow it down. If you need phosphate replacement, we'll give it to you. And subhanAllah, later they will come happy with the results that they got from the IV iron. Now the second question was about sickle cell anemia requiring iron supplementation. So I was very cautious bringing my term about sickle cell trait. They are not normal people. Okay? They are patients with sickle cell trait. Sickle cell trait can give. There is a high risk for renal medullary carcinoma. Sickle cell trait from the Olympics in 2010, which happened in London, they pulled back some athletes because they know that whenever they go into very severe form of dehydration and strenuous exercise, they will start to have vaso-occlusive crisis. It has been recorded in the military in Iraq when the American troops actually came and they had some African American in the group. They actually started to develop vaso-occlusive crisis, although they are sickle cell trait. So sickle cell trait, I'm saying you can't give it to them if they don't behave or they don't participate in very severe activities. You can give them iron because you can deal with them as normal people. The third one was about the level where you say I would give IV iron or transfusion. So remember at the beginning of my talk I said I don't like to give blood transfusion. We know it is very easily to give blood transfusion, but let's think about the side effects of blood transfusion. Especially in young ladies, you don't want to give them because they will develop antibodies and then later on they cannot get pregnant or they will find their periods. So remember, actually you're giving, I always like to say it, like you're giving an Abd al-Samir, you look at Abd al-Ali. Whenever it comes to Abd al-Ali, he will disagree. We always test for 5 blood groups, right? O, A, AB, B, and the RH group. We don't test for the other 36. Which is the extended match, the Kell group, the Duffy, the JKY, the JKB, and we find always this problem with the thalassemia and sickle cell disease because we don't test for them. Like for example, at the university right now, I have five patients under my name. They only have three blood bags across the kingdom. That's the only available blood bags for them because the fecal blood transfusion. So please avoid transfusion as possible. IV iron would be quicker in action than oral iron. I'm not saying give IV iron or oral iron, but the faster the process you want. If you have a heart failure patient in front of you, if you have a dialysis patient, if you have a pregnant lady in the last trimester, please give IV iron.
I agree the sickle cell disease, the level at which should be improved with the issues.
Yeah, we do not give IV iron for sickle cell.
At what level you transfuse to the heart?
As another question for us, we always look at their baseline. If you come to a hematologist and you don't bring your old CBCs, the hematologist will have a seizure in the room. So you always have to bring the old CBCs out there to check what is the baseline, and accordingly we will be transfusing. But there are certain times, if the patient has priapism, if the patient has acute chest syndrome, if the patient is going through stroke, or the patient is going for an OR, for a